Okay. Okay. So let me, oh, why is this not advancing? Oh, there we go. These are my obligatory disclosures. I sort of consult with a number of companies and on speakers bureaus and have some research support from private foundations as well as the federal agencies. And I'm going to start my discussion with a very classic approach to thinking about seizures, and that is an imbalance between excitation and inhibition. Excitation is seen usually as either aberrant sodium channel function, and now we all know that because everyone knows about SCN1A, which is a sodium channel gene, right? Or increased excitatory synapse function, which is basically glutamatergic aberration. On the inhibition side, we have K channel may be impaired. I think everybody in pediatrics now is very preoccupied with KCNQ2 and 3, or KCNT1, KCNA1, and so on. And or it can be an aberration in the GABAergic function. So what I want to do is use this illustration of an action potential, but then point out to you that to understand it, we have to kind of connect it to some of the genes that code for the relevant proteins. So I took this illustration and superimposed my approach to it, which is to show you that on the upstroke of the action potential, we have a number of potential sodium channel genes. The currents are mentioned with the Na for sodium. The subscript V is for voltage gated. Okay, so we have NAV 1.1, which is SCN1A product, and SCN2A corresponds to 1.2, and 8A actually corresponds to NAV 1.6. And I also want to observe that in the next phase, the channel has to close. And here, the NAV 1.1 actually closes very rapidly. So the biophysics of these channels is not identical. 1.6 can often be slow. And not only that, it can also be unstable and reopen without intent in conditions like epilepsy, okay? And then repolarization involves potassium channels. So one of the key factors here is KCNA, which is KV 1.1. Then, of course, we have other potassium channels we know about that occur more in the hyperpolarization area, like KCNT1 and KCNQ2 and 3, which is KV 7.2 and 3. So this kind of gives you a little bit about how we are going to begin to talk about pharmacology. I think everybody knows KCNQ2 encephalopathy or benign neonatal convulsions. This is that KV 7.2 heterotetramer channel, meaning there are two KCNQ2 subunits and two KCNQ3 subunits together from this channel, connected to anchorin structurally. And we'll just go to this top diagram to show you that the presence of this current, which is called M current, because historically this was felt to be mediated by muscarine. Thanks. And when you look at the M current, when it is suppressed, you get this orange stroke of return from hyperpolarization, repolarization. And over here, what you're seeing is with the injection of M current, the state of hyperpolarization lasts longer. So if you come to this diagram, you see when there is a current injection to form spike frequencies, and then when you activate the M current, notice they become less frequent. So it's a synchronized firing. And that's the KVN 7.2. This just shows you what the channel looks like. Okay, so now we go to the next slide. And this is a slide I borrowed a long time ago from Mike Rogowski. And what I want to show you is an incoming impulse here causing a wave of depolarization. This sodium entry actually triggers calcium entry in the synapse. And this activates CAM kinase, which interacts with SV2A and the synaptic vesicle to cause release of neurotransmitter. And then downstream on the glutamatergic synapse, you can have kainate sensitive receptors, AMPA or NMDA. And in terms of the medications you commonly use, kainate receptors are very sensitive to blockade by topiramate, AMPA receptors to perampanel, NMDA receptors to compounds like felbamate. And then this causes a EPSP. And then if you think about medications, the most classic target is this sodium channel. This is where phenytoin, carbamazepine. So these are all presynaptic drugs. Over here is where we have gabapentin and pregabalin. And not shown in this diagram down here is where we have levetiracetam, brivaracetam. And then these I mentioned to you already, okay? So coming to the old classic understanding of the sodium channel, here is the sodium current, and carbamazepine binds to the open channel to block it. So we call this a use-dependent blockade, because basically the channel has to open first. So you get a few action potentials, but you don't get what we call sustained repetitive firing when carbamazepine is on board. Okay, that's the classic use-dependent blockade. And this is a little more of showing you how things are. So bottom left over here is the resting state, and you can see conformationally the channel is closed. And when you have a wave of depolarization, the channel opens here at this constriction to let sodium get through. Then within a millisecond or two, there's a temporary closure. This is the inactivation with a ball and chain type of approach. And then as the membrane repolarizes, then you begin to see this is supplemented with a conformational change over a few seconds, milliseconds, and now we are back to the resting state. So this whole process is what we call fast inactivation, because it takes just a few milliseconds. But we also have another mode, which is a slow process. Okay, so here I show you the fast inactivation. This is within milliseconds, and then repolarization to resting state. And this is where carbamazepine, as well as phenytoin, lamotrigine, all these compounds are. Note that cenobamate occurs here among the new drugs. Then the slow inactivation is where you have learned about lacosamide. What may surprise many people is wherever I give this talk, the residents typically think S-carbazepine works very similar to oxcarbazepine, but it actually doesn't. S-carbazepine is more like lacosamide. And I'll show you a little bit of data. Here's some physiology of slow inactivation. This is for carbamazepine. You see very little effect compared to the resting state. Over here on the right is lacosamide, and you see on the left S-carbazepine. Okay, so this is how S-Li works. Now I want to take our discussion to shaping of cortical activity by inhibition. In these illustrations, the principal cells are in gray. They kind of look vaguely pyramidal. And then the bipolar looking thing in turquoise is an inhibitory GABAergic interneuron. And in feedback inhibition, the output from the pyramidal cell activates the inhibitory interneuron. Over here, you have feed-forward inhibition, where the incoming stimulus activates both the inhibitory neuron and the principal neuron. And then this provides inhibition with GABAergic synapses. Okay? And the next point is to notice that these cells, the bipolar GABAergic cells, actually use NaV 1.1. So SCN1A, that gene, its product, is mainly occurring in these. There is no SCN1A product in the principal cells. Okay? So pathologic excitability here may involve NaV 1.6, which is actually the SCN8A product. We also tell you historically don't use sodium channel blockers in Dravet because the Dravet mutation occurs here, right? So the inhibition is already impaired. And if you inhibit it further with a sodium channel blockade of NaV 1.1, they just can't fire. Okay. So in the next slide, it looks like a lot of words just to tell you that this is a paper from classic paper from Journal of Neuroscience. The key thing I want you to focus on is what's highlighted in green. That is, NaV 1.1 can only be detected in GABAergic interneurons. That's a very, very important statement because, as you know, classic sodium channel blockers, phenytoin, carbamazepine, ox-carb, they are not selective. This is why you don't use them in Dravet, but even in a non-Dravet situation, there is no real advantage to blocking inhibition, right? Teleologically, we have a purpose why we have an inhibitory system. We don't want to really kneecap that when our goal is to block too much excitation, okay? So moving on, this is from that paper. You can see NaV 1.6, KV 1. All of them are mainly in the axon initial segment. See, there's no signal in the soma, okay? So the axon initial segment not only has NaV 1.6, it also has the KV 7.2. This is the KCNQ2-3 channels, okay? And another classic paper on Dravet syndrome, going back to almost 17 years ago from Ojiwara and colleagues, that shows you where NaV 1.1 is present and the signal is seen exactly coincides with those that co-localize parvalbumin. Parvalbumin is classic for a subtype of GABAergic interneuron. So when you see parvalbumin sensitivity, there are many types of GABAergic neurons. They all co-localize different types of peptides. Some co-localize somatostatin and so on. So these are the parvalbumin. And so this is just to confirm. Now we have a schematic to show sodium channel-wise NaV 1.2, which is SEN2A product, and NaV 1.6, which is the SEN8A product, are very busy in the axon initial segment. If you see, there are more greens proximally, and a little bit further, there is more NaV 1.6, and 1.2 has a higher threshold for firing. So it makes sure that excitation moves down the axon and not retrograde, right? Because NaV 1.6 is going to fire faster, sooner, with a lower threshold. And this is the same area where we have KV 7.2, KV 7.3. And here you also notice NaV 1.1 compared to 1.6 has a narrower profile. I told you it's very narrow, fast spiking, right? And so now we come back to this illustration that occurs in many, many EEG textbooks. It's usually EEG 101, tells you that this scalp interictal spike, when you record intracellularly, corresponds to a little bump that we call paroxysmal depolarization shift, on which there's a train of action potentials. What I want to point out is paroxysmal depolarization shift is a fancy name. A simpler physiologic name would be there is a sodium current that depolarized, presumably sodium. They used to think it was calcium, more about that in a minute, but it's a depolarizing current that's not sharp and coming back down. So in physiology, we say it's a non-inactivating current. Okay, on that you have those spikes. Okay, so we used to think this was calcium, like here it says non-NMDA, NMDA, etc. But now we know, actually, we are more interested in the fact that they could be what are called persistent sodium currents. Okay, and on the next slide, I blow up that diagram, show you the paroxysmal depolarization shift, and tell you non-inactivating currents are often mediated by NaV 1.6. And then here are spikes that in excitatory cells, these can also involve the same sodium channels, but in the fast spiking GABAergic interneurons, it's NaV 1.1. Okay, so action potentials are the transient sodium currents because they inactivate very fast. The PDS, or paroxysmal depolarization shift, is a non-inactivating. That's why it's called INAP, or persistent. And it's encoded usually by SEN8A. And here you can see again very clearly with a variety of holding potentials. Here is the transient current. Oops, sorry about that. And here is the persistent current, right? And I also want you to know that this unstable current, the persistent current, actually seems to go up during a process of epileptogenicity. There is this reference to Chen et al. It's a paper by my friend Heinz Beck in Bonn and Hoel Yari from Israel. They showed that if you take rats and subject them to status epilepticus and observe them longitudinally as they develop temporal lobe epilepsy, they start developing bursting cells. And the bursters are INAP. So the idea is the persistent sodium current is a response to an injury, right? So now if you did, they published this mainly as a physiologic study. Now, if you are a DNA jockey, molecular biologist, you may demonstrate in that same animal that SEN8A expression has gone up, right? To give rise to this excitability. If you have more PDS, you can form more action potentials because it takes the membrane potential closer to threshold, okay? So this is kind of an important schematic that I designed to show you that here is GABA interneuron with NaV 1.1. This needs to be active in order to squirt GABA for inhibition. Over in the axon initial segment, we have NaV 1.2, 1.6, which seems to be plastic after injury, Kv 7.2 and 3. So if you can use medication to block these and not NaV 1.1, right, that would be a great advantage. Unfortunately, all the classic sodium channel blockers do not have that selectivity. And however, here comes cenobamate. You notice in this paper from the European Journal of Pharmacology, it had very little effect on the peak component of the transient current. Remember the one we talked about, SEN1A or NaV 1.1? And it potently inhibited the non-inactivating, the one that forms the PDS. So in illustration, you can see here, when they measure transient current, cenobamate and control almost overlap. Over here, if you look at INAP, here is control and here is cenobamate. And on the right, you see a dose response. You can see that cenobamate can block persistent current, the PDS with the dark circles, at an order of magnitude lower concentration than on INAT. So if you're in the concentration range here, you have no effect on GABAergic interneurons. That's new for a sodium channel drug. And that may be why, here is a paper from Berlin by Makridis and coworkers showing 4 adult patients, this is on the y-axis, seizures per month, and 0 point is when he put them on cenobamate, and you can see what happened to seizure frequency. Contrary to what we've been told, this is because of the selectivity where it does not block fast spiking, action potentials. So the people of my, tribe, medicinal chemists, have gotten very excited about this idea that how about making compounds that are subunit selective for NaV 1.6, which is the SEN8A gene product. And a large number of compounds have been made, but this is a good compound to illustrate the concept. If you look at this compound, come down to this dose response curve below on the left bottom, the inverted blue triangles are NaV 1.6. The red circles are NaV 1.1. If If you see the distance between these two, you can see that's easily 3 log units, right? That's about 1,000-fold different. So at any realistic concentration, when you are blocking NaV 1.6 even fully, like 1 micromolar, there's very little effect on NaV 1.1. So come to the right side, when the red hatched box, I show the effect of carbamazepine on pyramidal neurons versus fast spiking interneurons. See, in both cases, it limits those current. But you come to this test compound, you see on cortical pyramidal neurons, the effect is very similar to carbamazepine. Notice it's also very potent. Here you have 100 micromolar, here you have 1/4 of a micromolar, right? And then you see on the interneurons, carbamazepine blocks them. And over here, you see very little effect. So this is kind of the emerging story of sodium channel blockers. So here is again one compound that is very selective for NaV 1.6, the blue inverted triangle. Then you see the orange boxes are NaV 1.2. Here's a compound that's very strong on both 1.2 and 1.6. And down here, you have phenytoin carbamazepine with no selectivity at all. So the story is, if you have a SCN2A patient, this may be a fun compound. If you have a SCN8A patient, this could be. But either one of these compounds should help all of them significantly. And of course, that may be underlying pathology even in temporal lobe epilepsy coming after hypoxic ischemic injury or something like that, okay, or post-status. So they may be very, very interesting compound. Here again, we show phenytoin carb working on both GABAergic interneurons with NaV 1.1 and excitatory with NaV 1.2 and 1.6. And these are the more selective compounds. Note that the purple and magenta don't go to the GABAergic interneuron. So if you don't remember all the details, you are constantly thinking and talking about SCN1A, SCN2A, SCN8A. Now you know a little bit of neurophysiology to go with it, and that you can manipulate them sensitively with emerging compounds. So that's kind of the biggest point of inflection in our development of new drugs. This is why I really enjoy having a scotch with Martin Brody, but I'm not too, I don't care that much about Kwan and Brody finding. When we say, oh, we're not really moving it, well, that's because, we went from carbamazepine to oxcarb to all these compounds. They're all non-selective anyway. So why would they make a big dent, right? So the other interesting thing was discovered by Indira Raman, no relative of mine, was at Harvard, who found that the SCN8A type of thing can not only cause poor inactivation, meaning persistent current, they can also reopen without intent. That's what's called a resurgent. So in this diagram, you see there is not only INAT. Here, instead of INAP, we show INAR because it starts, repolarizing again. And that's because the initial inactivation is very unstable and it kind of has another current, right? So again, not a very healthy situation. And so here's a compound that actually, here you can see SCN8A mutant showing a strong resurgent current, right? It is a blow up of this. This was not intended, right? This should be like this. So here you see it is able to limit resurgent currents by limiting NaV 1.6. And perhaps unknown to you is NaV 1.6 sodium channel activity may be responsive to cannabidiol. So here is a strong resurgent current, and this is purple is with vehicle, and with 1 micromolar CBD, you can see this has been truncated. And over here you have, again, The purple one is vehicle, black one is the cannabidiol, and you have a significant effect limiting it. And now you can look back and say, that's very interesting that there is some selective inhibition, like these people, CBD preferentially inhibits resurgent currents over transient currents. That's a good thing because the transient currents are driving your interneurons, right? And it's no surprise that the first indication for cannabidiol was Dravet, right? So it kind of comes together, even though it has other actions as well. And this is a paper in a different system from Stephen Petru. Here, the difference was more subtle and not pronounced. So there's a little controversy. But I want to show you the fraction of people who became seizure-free. You see a lacosamide only 2.6, Esli 8.2. All these are single-digit numbers. And then you come to cenobamate, all the way to 21%. So my conclusion is this is the enhanced action of cenobamate and its wider application is because it does not kneecap inhibitory interneurons. That's kind of an important message to you as a clinician, right? So we come to the GABAergic side. I love this drawing because it has been over the years modified, but it's kind of evolved from something Dr. Jong Ro at Rady Children's and I, when we just finished our residency a long time ago, started working on writing a review. So this goes back a while. So anyway, this just shows you glial cell and the presynaptic having GABA transaminase that you can inhibit with vigabatrin. You have GABA transporter that can be inhibited with tiagabine, and then the released GABA can act. And at that time, we only knew that benzodiazepines, barbs, acted on this allosterically to enhance the GABA-mediated chloride current. We knew felbamate acted a little bit like a barbiturate. But there are things that we did not know in '99. We learned later that are really important. One of my least favorite statements from epilepsy fellows is when they refer to drugs as, oh, it's a GABA drug. I don't like that because GABA drugs actually have subtypes that are really, really important physiologically. So here's a schematic I drew many years ago to teach. Here is the GABAergic synapse, vesicle containing GABA, the GABA transporter. This is where tiagabine blocked. And here is the synaptic cleft and postsynaptic GABA receptor with alpha-1 or alpha-2 subunits and gamma subunits. Let's see what that means. Alpha-1 and alpha-2 confer very low affinity. Now, when I first say that, a lot of students are very shocked. That's an important synaptic receptor. What do you mean it's low sensitivity? Well, low sensitivity means it doesn't have a lot of noise. Low sensitivity means it activates only when you have a quantal release of the neurotransmitter and the synaptic concentration shoots really high. It does not respond to mild ambient fluctuations because it's for signaling. And we said it's these interneurons fire rapidly. Remember that? Sharp action potential. They rapidly inactivate because you can't really signal if you don't inactivate. How do you get the next message out? So for signaling purposes, low affinity and rapid inactivation makes sense. The gamma subunit is necessary for benzo or barb binding. And over here, we have another type of GABA receptors that are extrasynaptic. They turn out to have alpha-4 or alpha-6 rather than alpha-1 or 2 subunits. And they're actually super sensitive. And their current is non-inactivating. So what they do is they hyperpolarize in a fashion that is like a mirror image of the paroxysmal depolarization shift, only in the opposite direction, right? So they are not sensitive to benzos or barbs because they don't have a gamma subunit. What the delta subunit gives you is sensitivity to two important classes of compounds. One that is endogenic and physiologic, is metabolites of progesterone. They're very sensitive. Their current can be augmented by tetrahydrodesoxycorticosterone or allopregnanolone. Okay? In terms of foreign compounds, that is the site of action of general anesthetics. So now you may recall that during refractory status, you sometimes resort to general anesthetics. That's because another story about these receptors is if you continuously activate them, they get internalized. You lose the target, but these don't get internalized. So that's why when you go to general anesthetics, they work. Okay? So here is a review by Benarock showing the same things. See, subunits have gamma 2 and then alpha 1 through 3. Over here, you have delta and alpha 4 through 6. And it shows here phasic inhibition, right? Rapidly inactivating. Tonic inhibition doesn't inactivate. And you can see here GAT transporter, all these things. And here you see astrocyte having some neurosteroid metabolism. Okay? So progesterone metabolites are allopregnanolone and TH-DOC or tetrahydrodesoxycorticosterone. Over here, you have ligands like benzos, barbs, ganaxolone. And over here, you have ganaxolone and cenobamate. So we have two drugs that actually act significantly on the extrasynaptic. Okay? The other important topic is to realize, going back to this illustration, you may want to think about this as a clinician. Let's say you have a patient who's doing fairly well on lacosamide, but her periods kind of pop out every time during periods, right? And you have been using historically, or maybe during those few days, you take a small dose of clonazepam or something like that. But let me give you an alternate thought. If you think during the period, the corpus luteum is sloughed off, there is no longer progesterone synthesis, and its metabolites drop rapidly, and that the catamenial seizures are a manifestation of withdrawal of activation here by neurosteroid metabolites. If you conceptualize it that way, you may say, maybe I should switch that patient from lacosamide to cenobamate, because cenobamate will have some action here to support this neurosteroid withdrawal. We don't have clinical data because hardly anybody's taught serious pharmacology. But that's the kind of thinking that you need to bring to the clinic, right? So here is an illustration showing neurosteroid metabolites. There's allopregnanolone, and here is ganaxolone. The only difference is this methyl group. Allo is not orally bioavailable. It needs to be in an infusion. Ganaxolone can be taken PO, has a little longer half-life. Still short, about 4 hours. Okay. So this is the benzodiazepine, again showing you synaptic currents look like a reverse of action potential, right? Sharp. Extrasynaptics look like a bump. So now let me point out to you another cool things about cenobamate. If you are blocking NaV 1.6, it's hard to form a PDS. Without PDS, it's hard to form those spikes that give rise to the spike. But here, what you have is not only blocking PDS, right, to go away from the membrane potential towards depolarization, you're actually contributing to the I tonic, which is exactly the opposite, right? So now you're not even at the membrane potential, you're below, and you have blocked any ability to have PDS. So you can see why it's a very powerful anti-seizure at a cellular level. Okay. So benzos and barbs, ganaxolone, cenobamate. So if you think of cenobamate at that extrasynaptic GABA, where normally progesterone metabolites are, you wonder if it's a good drug for catamenial epilepsy patients, right? And this is just a paper showing you that with cenobamate, there is no reversal by flumazenil. That's because it's not at the synaptic site. It's not at the benzo site, okay? And we use this illustration to show you that in the synaptic side, they're rapidly internalized during status, and the extrasynaptic ones are available targets. That's where anesthetics act. But there are recent interest in wondering if we would avoid refractory status if we dosed patients, let's say they failed the first dose of lorazepam, and you're loading them with levetiracetam or phosphene or something. There is a proposal that by the company that makes Marinus that you should use a dose of ganaxolone and continue ganaxolone for 48 hours, right? And so that's one of the ongoing emerging things. Then we have chloride transporters. In the immature brain, we have a dominance of NKCC1, which pumps the cell full of potassium. So if you see the intracellular potassium levels, they are very high. With maturation, you see NKCC1 has shrunk and KCC2 has dominated, which actually extrudes potassium. Chloride rather. So when chloride is low and the GABA channel opens, chloride can rush in. But over here, when the chloride is high, what happens? Chloride leaves the cell, and that will be excitatory, right? That's the excitatory GABA. So there is a possibility that these transporters may be promising drug targets. It is again showing you immature neuron, high chloride because of NKCC1, and very little KCC2. So when the GABA receptor is activated, you get depolarization, excitatory GABA. In the mature neuron, very little chloride inside because of KCC2, which pumps it out. So when the GABA channel opens, chloride goes in, causing hyperpolarization, the inhibitory GABA. We also know from neonatal studies that bumetanide study failed, right? You're familiar with this classic paper in Lancet. And we have done a bunch of stuff with the bumetanide in our lab on baby rats, on kindling studies. We found it minimally effective on the very, very young and rapidly lost efficacy. However, the new thinking now is what, instead of trying to block NKCC1, if we stimulate KCC2 that's deficient in these situations. So this is a compound that was developed by AstraZeneca and is really a potent stimulator of KCC2. And so you can see in blue, it reduces neuronal accumulation and slows the development in slices. And over here is a paper in Cell showing that direct activation of KCC2 arrests benzodiazepine refractory status. So this is really kind of an emerging story and very exciting. We discussed it in the London meeting a few weeks ago. And here is a illustration showing how KCC2 is pushing chloride out. And with KCC2, combined with diazepam and this compound, Ovid 350, there are far fewer dead cells. And here the EEG power spectrum you're used to seeing. Here, even with diazepam given at this point, you see the power spectrum. And then here, diazepam with the Ovid compound, you can see a dramatic effect. Then finally, most drugs we talk about are acting on the cell membrane, presynaptic sites, postsynaptic sites, etc. But another type, some of them are ion channels, ionotropic, and there are others that are G protein coupled, right? Second messenger system. But there are also intracellular targets. For fenfluramine, it seems that it acts on sigma-1 receptors, which are a subtype receptors that are on the endoplasmic reticulum, where it kind of communicates with the mitochondria, changes calcium signaling, and therefore mobilization of excitatory versus inhibitory receptors to the membrane. So this is people are not thoroughly familiar with the serotonergic pharmacology because it's incredibly messy and complicated. We know that 5-HT1D is used in migraine. When it comes to the subtype 2, 2A is mostly used in psychiatry. It's a target for antipsychotics. 2B is responsible for cardiac valvopathy. It causes cardiac remodeling and fibrocyte proliferation. 2C is anti-seizure. So we have this cardiac echo for fenfluramine because it's non-selective. It acts on 2B and 2C. Then we have 5-HT3, which is where it's mostly in the base of the fourth ventricle in the brainstem and is responsible. The 5-HT3 antagonists are compounds that we block for vomiting. 5-HT4 has drawn a lot of interest for two things. One is 5-HT4 may be important in modifying SUDEP. I'll show you a little bit more. And it may be actually a positive thing cognitively. So here we remind you 5-HT3 is involved in emesis and etc. And 5-HT4 receptors are in the hippocampus and the brainstem. In the hippocampus, you can see enhancement of long-term potentiation, particularly if you do learning and memory tasks, it gets upregulated. On the other hand, it may be anti-SUDEP in the brainstem. And this is just to show you the intracellular sigma receptor and its role in calcium buffering. So what happens with the fenfluramine is it promotes GABAergic signaling secondary to G proteins and 5-HT activity. And this is the 5-HT2C, whereas the sigma receptor activity decreases glutamate signaling by changing the trafficking of receptors. And so this approach is not useful for historic, mesial temporal sclerosis type of seizures or amygdala kindling. It seems very unique for these developmental epilepsies. The other thing of interest is Carl Feingold's lab in Illinois found that they studied DBA1 mouse, which is by the way, normal mice live anywhere from 2 to 3 years, right? If they're kept well. The DBA1 mouse, generally, they're all dead by 2 months. So they have very, very severe spontaneous respiratory arrest. So Carl found that he's been looking at serotonergic mechanisms for a long time, more than 2 decades. But he arrived at this interesting finding that if he gave them fenfluramine, he salvaged a lot of them from respiratory arrest. Even more important, especially when you talk to patients in the clinic, he found that he did that at a much lower dose than it took to stop their seizures. So the message is, I tell my patients, if your kid is going to be on 3-4 drugs for Lennox-Gastaut, shouldn't at least one be saving your child's life from SUDEP? Because every year we lose a few to SUDEP. The other important thing is the benefit of protection may be present even if the seizures have not come down dramatically, because they seem kind of independent. And something that also emphasizes the role of brainstem and its manipulation to reduce SUDEP is VNS. We have good human data, registry data, that VNS reduces SUDEP. We used to think it's because of its seizures are better, but maybe not. Maybe even people whose seizures only have a modest response have SUDEP benefit, because the vagus nerve stimulation mainly affects locus coeruleus and the raphe. So it's also a way of serotonergic tweak. And we know it also has indication for depression. for the same reason. And Feingold also found that using specific compounds, selective agonists and antagonists, that it's a 5-HT4 subtype. So the 5-HT4 may also bring you some cognitive benefits, right? Because it's involved in learning and memory and SUDEP. And here is a human registry paper. I think everybody knows Helen Cross, a very close friend of mine for a long time, currently the president of ILAE. And you have other familiar names like Elaine Burrell and Oren Davinsky, Antonio Gilnagel. They all looked at this registry of fenfluramine exposure. And from that paper, I show you this, compared to the Cooper registry. Cooper et al. Paper comes from Ingrid Sheffer's group in Melbourne, where they first discovered all these gene and epilepsy connections. They have tracked SUDEP in Dravet patients all these years. So here you can see the all-cause mortality and fenfluramine. So it's not just in Carl Feingold DBA1 mouse. There's human data that seems to suggest. It's really important because sometimes families freak out when you say we need a cardiac echo. You have to explain that that's kind of a non-story. Nothing really happens, right? This is the real story. So I'm going to conclude with these thoughts. Evolution of highly subtype selective voltage-gated sodium channel blockers represents an inflection point in the development of new drugs, and it accommodates precision medicine for like SCN2A, 6A, et cetera. And they may be great for precision medicine for some genetic epilepsies, but they may also be good for a lot of acquired focal epilepsies. Understanding phasic versus tonic inhibition in the GABA system gives you new applications, including like we're looking at future treatment of status using ganaxolone type of thing. Novel future approach may include both for neonatal as well as benzorefractory status with KCC2 enhancers. Leveraging serotonergic may be a new way to think about epilepsies to modify SUDEP. And my final plea is patients will really benefit if our neurologists actually, instead of saying MOAs don't matter, I think they do, right? There is no sense in saying we have all these drugs, we are not doing better. We'll do better when we actually understand how to use medications wisely, right? So that's kind of my last statement. I hope it connected, at least to some degree, what you are routinely doing in the clinic with genetic testing, finally to a little bit of pharmacology. Okay, thank you so much.
Thank you, Dr. Sankar. It was an amazing talk. Thank you for opening our eyes to the ion channel blockers and the precision medicine. Thank you so much. So I'm going to open up to question and answer sessions. Any questions?
I'm very happy to hear about SCN8. Since I've struggled with these patients.
Exactly. Yeah.
Hearing the
Yeah.
and so that okay, there's a little bit of light at the end of the tunnel.
Yeah. There is.
So
I think there's very interesting things are happening on this front.
Again, I wanted to let the group know that it's downstate is known as Krakow country. Roger Krakow and Joan Krakow were reputable, well-known, and so we come from a wonderful pedigree. So your talk about, the electrophysiology and how the medications act, adding the pharmacological part of it, I am very, very happy. Thank you again.
Thank you.
There is a question in the chat.
Let's see. There's a question about refractory status. If I may plug something I published last year, if you Google or PubMed my name and status, you'll find a review in Epilepsia Open. There's a special issue to honor my mentor, Claude Wasterlein, who did 5 decades of research on status. And I did a lot of status work with him. So I wrote an article that actually is very critical of current clinical practice. It talks about not wanting to really thrash out refractory versus super refractory, because my proposal is that we shouldn't be going there. The difficulty with our current clinical practice is everything is happening very late, right? Time is brain, and the emerging proposals are actually beginning to recognize it. So one of them is the proposal for ganaxolone to be used right in the ED when you're getting loaded with the drug that follows your first round of benzo. The other approach, there's a grant proposal that is very likely to be funded. I think many of you who do status know Tom Bleck from Chicago. Tom Bleck and Jaideep Kapoor from UVA are major drivers behind it. That is how to use ketamine properly, right? So the receptor trafficking things, we have done a lot of studies in rodent models using either lithium pilocarpine, electrical hippocampal stimulation, in all of those, and classic papers from Howard Goodkin, Claude, you see this GABA receptor internalization of the synaptic ones is very, very complete in 40 to 60 minutes. At the same time, Jaideep's lab also showed that there is an activation of NMDA receptors that secondarily promotes increased trafficking of AMPA receptors to the synapse. That's also occurring in the first hour of status. Our problem with all the clinical reports on ketamine, if you look at them, I allude to a lot of this in my review, they always say, oh, we tried ketamine on somebody who we couldn't get them off of pentobarb coma. They've been seizing for 1 week, 2 weeks, 1 month. See, that's really not when you should be acting to treat status. You want to prevent refractory status, you need to be conscious of the physiology. The physiology is you're losing benzoreceptors and you're increasing excitatory receptors. So if you're going to use either something like ganaxolone to activate extrasynaptic GABA or ketamine to block enhanced excitatory receptor mobilization, they should be occurring in the first hour. So the new grant from Bleck and Kapoor and others proposes exactly that. So the way we are looking at it, the center of action is not the ICU with the anesthetic drip. The action should be gradually with proper education and early neurology consult should be moving to the emergency department. Because usually it's several hours before the patient's in the ICU, right? So these things need to happen immediately when you are loading with the, what we call the second line. First line being you gave them 4 milligrams of Ativan or something, and typically they're still seizing, right? Before you call it status, you need to block these receptor movements at that time. That's kind of where I see the future. We should not have refractory and super refractory. Doing things after weeks of status gets really messy. And extensive putting people in coma is fraught with high mortality. If you put them on a lot of pentobarbital, it completely uncouples oxidative phosphorylation. So if you put them on a coma and then say the blood pressure is dropping, I'm going to use an inotrope, that's really bad news. You are stimulating the myocardium, but you have blocked its ability to make ATP. So it's not uncommon that people have a cardiac death in the treatment of status. So we really need to be doing things much sooner. Yeah. Any other, I hope that makes sense. But I would go back and say, I'm reading, if you are trying to do anesthetic drip, at some point with the NGT, I would try definitely perampanel or cenobamate. Perampanel would make sense if you have a lot of AMPA action, and cenobamate would be GABA sparing, right? So those are kind of more interesting than some of our older drugs. Okay.
A question.
Yeah.
A question about the KCN mutation. So if I'm not wrong, even familial neonatal seizures are related to KCN mutation. At the same time, Ohtahara or epileptic encephalopathy is related to the same KCN mutation. How can it be so much different in phenotype?
Phenotype, yeah. That, this is the KCNQ2 mainly.
Mhm.
The mild mutations actually don't completely clamp down, depolarization. They actually are somewhat functional. And so you have these neonatal benign convulsions. They usually resolve over several weeks because GABAergic inhibition becomes more potent, right? Because you are replacing NKCC1 with KCC2. And so you don't have seizures in the more mature person. But the ones who have the Ohtahara-like encephalopathy have very, very severe one that cannot be compensated.
Understand.
Yeah. So for those, we hopefully will have more powerful openers of the KCNQ2/3 channels. We used to have a medication called retigabine or ezogabine that was withdrawn due to toxicity issues. But there are interesting pipeline compounds. There is one set of compounds being developed by Xenon in Vancouver. There is another really interesting compound, but I'm conflicted because I'm on the data safety monitoring board for Biohaven, because their chief medical officer is one of my former faculty from UCLA, Jason Lerner. So they have a compound that is just called BVH 7000 that may potentially have application. But interestingly, that compound was proposed for clinical trials for epileptic encephalopathies. The FDA is a very conservative organization. So they totally disappointed us by saying, no, we can't let you do any trials on the babies until you have proven safety in adults. For the moment, adult focal epilepsy trials are underway. So eventually, I think we're going to have some choice of KCNQ2 openers, and we'll see how they do. But the limitation to all this is the brain has already developed with these abnormalities in signaling to some point. The idea again with KCNQ2 would be, if that's a problem, we should really address it early. But hopefully in the future. Yeah.
One more question.
Yes.
What are your thoughts on the epileptogenicity that we see in autistic spectrum disorder? Again, it's not one disease, but.
Yeah, that's very complicated because it's such a mixed bag. It may not be one simple thing. And then, some of the channelopathies are really interesting. SCN2A is a good example. Gain of function gives rise to epilepsy. Loss of function is strongly connected to autism. The other challenge to precision medicine, I think you all know about the failure of quinidine for KCNT1 disease. It's not just KCNT1. There are papers showing TACNA1, CACNA1, which most people associate with familial hemiplegic migraine and episodic ataxia, has been found in some Lennox-Gastaut. But the disturbing thing is both gain of function and loss of function. So some of them kind of have this Goldilocks type of requirement that they need to be just right. They can't go in either direction.
How
Well, little louder.
So
That actually, it does work. You know, it doesn't reverse the whole encephalopathy, but there's a number of papers, one of them was in the Neurology Green Journal by Adam Newman's, one of our corpus fellows. Some KCNQ2 patients, your first attempt is sodium channel block because of the coexistence of those channels on the axon initial side. But with a lot of them, you know, the brain has been sort of doing a lot of plastic wiring with this channelopathy. So there's no real magical solution. That unfortunately will also be the limitation of gene therapy, depending on when you do it.
How young is the youngest person you have used cenobamate on?
Well, the label is for adults.
Yes.
In our group, we have a significant number of kids in the 8 to 12 range. But Dr. Sean Hussain, my colleague who does a lot, runs the epileptic encephalopathies clinic, he has a lot of kids even as young as a year and a half or two. And curiously, somehow they've been able to get coverage. Insurance companies are not trying to block us from using cenobamate. So we have a sizable population. We have to write a paper in the near future. Using cenobamate in young people cognitively causes them to affect. Why would it be any worse than less selective sodium channel? Yeah, I don't think it would be good.
when we talk about the cognitive aspect of all this, the seizures itself is causing cognitive.
Yeah, exactly.
Of course, we want something to blame it on.
Yeah.
And so, of course, the medication is a wonderful target.
Yeah.
But I said, without the medication, there's already so much damage going
Yeah.
on.
Right.
That I'm less likely to blame it on medication rather than saying
It's
it is
easy.
the innate seizure.
But within the medication, you can make choices, right?
To hear this question, you know, since again, pediatric studies don't get done till, you know.
Very late. That just,
Maybe our children can't wait.
yeah, this is a problem with the FDA's.
But it behooves us.
Yeah.
In the, you know, front lines to say, to understand what is the
Yeah.
drawback. And, you know, if there is like the Depakote, if it's not going to wipe out the liver
Yeah.
or anything major,
Yeah.
we need to be bold enough because,
Well,
you know,
with the-
it doesn't prevent us from
The
using it.
FDA is not a purely scientific organization. It's subject to political pressures. You may be very surprised how they really play hardball with most pharma. But they approved vigabatrin for infantile spasms and TS, despite the fact that the only study they had, companies had bailed out of vigabatrin long time ago, the original companies. The ones, the FDA approval came from a study done by my former boss, Don Shields, and Roy Elterman. That was not a real efficacy study. It was a compassionate study where it was given to people who had failed in other things. So that was not a high-class study at all, right? But the FDA went for it because the TS lobby is very, very strong. They fought for it. The TS lobby is so strong that you can get tuberous sclerosis grant of all things from the Department of Defense. Even though it has no relationship to, you can understand them funding post-traumatic epilepsy, but they actually fund TS grants. The lobby is very connected.
Thank you, Dr. Shankar.
Okay.
Thank you all. Have a great weekend.
Somewhere you have.